So we're starting to let people into the room, um, and my phone is ringing, so I'm going to stop it if I can. Thank you. So welcome everyone, and we have a large group joining the discussion today. For those that are old hands at this, you know George Rutherford. He and I have been talking to each other actually even before the pandemic, but we've been talking under this banner before, and we aim for these to be just very informal chats, really. And what we're obviously focusing on is COVID-19. George is a pediatric epidemiologist by training, but has done public health work both in the HIV epidemic and now, of course, in the COVID-19 pandemic for a very long time, and is incredibly knowledgeable about a broad set of issues. So we hope to tap into that today. We've also asked registrants to send in questions ahead of time. I have a very long list of questions that we'll try to get to, but I think it's probably time to get started. George, do you want to introduce yourself and then we'll get going?
Yeah, hi, I'm George Rutherford. I'm a Lucia Professor of Epidemiology and Preventive Medicine, and I have appointments also in pediatrics and the history of medicine here at UCSF. And I'm the head of the Division of Infectious Disease and Global Epidemiology in our Department of Epidemiology and Biostatistics. And it's a pleasure to be here with everyone.
Great, George, thank you. And I'm Paul Volberding, Emeritus Professor now of Medicine and Epidemiology and Biostatistics at UCSF, and enjoying watching things happen in this pandemic. And we can talk a lot more about that. George, let's get started. So I was with my family over the weekend. We had a nice weekend away. It was my first airplane flight in over a year and a couple of months. People on my flight were behaving themselves. Everyone was masked. No one was objecting. But out on the streets, it's now increasingly unusual to see a mask. So the question is it over? Are we done with this thing that we've been living with? What's your thought?
It depends on where you live. If you were living in India, you wouldn't be thinking it's over. And there's a real, interestingly here in California, I have a colleague at Stanford who went to Paso Robles over the weekend, which is about halfway between Los Angeles and San Francisco. And
right.
Paso Robles is sort of on the northern half of that divide, and San Luis Obispo and Morro Bay are on the south half. And she said everybody wore masks in Paso Robles and nobody wore masks in Morro Bay. So it's a real Northern California, Southern California divide. But we're pretty close to it all being over. I think here, at least here in California. But again, it really depends on where you are. There are some outbreaks that are still going on here, mostly in the far north of the state, kind of up near the Oregon border. And there are also outbreaks in Southern Oregon, but, and kind of scattered here and there around California, but it's get around the country, but it's really going down, down, down.
So when I was flying, we were flying again to Southern California. My son and his 1-year-old daughter were flying, not in the same plane. And I get why it was good for her to have people around her wearing masks. But I'm vaccinated, my wife's vaccinated. Why did we wear a mask on that flight? I'm not at risk, I don't think, for getting this anymore.
No, but if you had 15 people on that flight who were unvaccinated, they could have had a cluster on the plane. It's transmission on airplanes is pretty unusual. Most of the transmissions that have occurred have been on really long haul flights, like from Europe to East Asia or Europe to Australia. So I going from here to Palm Springs, Paul, I don't think is any biggie.
Right. So, George, I don't have a script here in terms of anything that's really logical or coherent, so I'm just going to go ahead. But one of the things that we've been hearing about is the possibility that because schools are kind of finding it hard to enforce vaccination, one of the concerns is, will there be a fall surge as schools start up again in person, probably largely maskless? What's your thought about that? And again, I'm sure it's going to be depending on where you are in terms of the risk.
Yeah, so I think that it kind of depends on what the level of vaccination is. In high schools where we've been able to vaccinate 16-year-olds for a couple of months now, I suspect they'll be pretty much immune. Middle schools where we've only really been able to start here recently in the last few weeks, I will suspect they'd be pretty much immune too. The 5 to 11-year-olds, those trials will likely end in October, and we may be able to move them forward. And the littler children are going to come later. There are trials for 6 months to 2 years and 2 years to 4 years. Those will come later. But what I think will happen is that kind of depending on where you are and depending on a lot of issues with teachers and teachers unions and, all that, kind of all the whole world of occupational medicine, that the kids may be required to wear masks. Certainly in elementary schools, I would assume they'd be required to wear masks because they are, they're going to be non-immune unless they've been naturally infected. But among older kids, you may see a push towards requiring vaccination. A little hard to do with the vaccines not being fully licensed yet. But the applications for the BLAs have gone in for both Moderna and Pfizer. And I think they've requested to go down to 12 years of age. I know that Pfizer has, I think that Moderna may have as well.
I think so as well, yeah. We saw over the weekend that I think the world's largest sporting event, Memorial
I
Day
saw that too.
500 happened, 140,000 people or something, down from their maximum from previous years, but still 140,000 people in the same place. But it's outside. What's your sense as sports kind of, everyone I think is eager to get back to, watching baseball, watching whatever sport you're interested in. What's your comfort level with big crowds, either outside or big crowds inside, but in big venues?
I think you have to be a little uncomfortable still. Again, it's not about vaccinated people getting exposed. It's about having clusters of unvaccinated people. And until we can get to something a little farther down the line, a little higher vaccine coverage, we're not really going to have herd immunity, and we can propagate transmission. That's the concern. And so outdoors is better than indoors. But I didn't see a single mask in the whole Indianapolis 500. I was looking. I have great shots of the Kentucky Derby as well.
Right.
Very few people with masks on, and everybody's yelling their heads off and stuff too. So I think that it's, we're still a little ways away from being able to do that with impunity. But we're getting closer all the time, and it really depends on what the vaccine coverage levels are, and those are going to be different in different parts of the country.
George, I know that I'm seeing questions coming in already. So I think one of the interesting changes that we're seeing in our programs that we've done here is that now, as more and more people have been vaccinated, we could try to take a poll of the registrants, but people are asking questions about their own risk now that they have been vaccinated. And one of the issues is, what's the likelihood that because of waning immunity from a vaccine, we're going to start seeing more people that are getting infected who've been vaccinated? And how are we tracking that? It sounds like the CDC is not planning on any systematic tracking of infections or mildly symptomatic disease in people who've been vaccinated. Who's going to be pulling that weight for us? We all want to know the answer.
So you've asked 3 questions there.
Yeah, that's good.
So to start with, people who are vaccinated, start with what causes vaccine failures. And the largest reason for vaccine failures is mishandling of the vaccine. So you're injecting saline instead of a biologically active ingredient. And this is the mRNA vaccines are pretty touchy, right? They're pretty delicate. And so you can imagine as you increase the number of distribution sites, which is what we're going to have to do if we're going to vaccinate, younger adolescents and children are going to have to go out to pediatricians' offices. Last time I looked, there were a lot of -70-degree freezers, even though you don't need that anymore. I realize. But still, these are delicate, relatively more delicate vaccines. They're not really hardy things. It's not like giving tetanus or something, or tetanus toxoid, I should say. So that's one thing. So the reason that people fail vaccine is largely because of mishandling. I think the other thing to point out is that certain people may be less likely to have a robust immune reaction. People who had solid organ transplants, who are immunosuppressed on immunosuppressive therapy, maybe people who are very old, although that seems to be pretty robust in them as well. But there is a concern among people with rheumatologic disease and organ transplants and stuff that they may not be as likely to have a robust immune reaction. So that's kind of still being worked out. If you're not in those, if you don't have that problem, I think you're golden. You're done. We're done, right? There are the failure rates currently are at about 1 in 10,000, probably a little less than that, but it's still vanishingly small. And as I said, remember that the main reason is mishandling. So what I'm thinking is that as we move down the line, we're going to have to keep an eye out for vaccine failures, and for a couple of reasons. One is waning immunity, which is, I think that's a bit of a misconcept because, we have both cellular and humoral immunity. The antibodies wane, obviously. If you're kept to antibodies for everything you've ever experienced immunologically, your blood would be like jello. Right. And, that's why we have memory cells. And as we get an increasingly sort of sophisticated look at what's going on immunologically, I think we'll find that we have quite robust immune reactions on re-challenge. Now, then the next question is what's going to happen with variants? Okay, and the current variants seem to be amenable, more or less, to the vaccines. There are
alpha, beta, gamma,
all of the above. All those goodies, all those good things. Yeah, and we may eventually come down and have variants, and we might need additional vaccination, much like we have required for influenza because the strains change. There's enough of antigenic shift, but we have to look for that stuff. And what CDC has said, and the California Department of Public Health has gone along with this, by the way, is that we're not going to do nationwide surveillance for breakthroughs, through vaccine breakthroughs. They're just too rare. It's just too taxing from a kind of a resource standpoint to do that sort of thing. Because in order to do it right, you have to do PCRs on everybody every week, right? To actually find that stuff. And so they're putting their money into a handful of cohorts to look for that. And then California, for instance, is just matching the immunization registry with the COVID registry as a real kind of poor man's option. But you're going to rely mostly on big cohort studies that are doing this. That's where you'll see this stuff happen, and kind of have a catch as catch can system, which is what was going on nationally. Seems to be, just not that great. And they are looking for both for hospitalizations and for mortality. So they're trying to catch the distal tip of it.
Right.
But we're going to have to rely on large cohort studies, mostly involving healthcare workers, to pick this up sooner. This is a classic example of sentinel surveillance as opposed to blanket surveillance across the population. So I think I've answered all 4 of your questions.
Yeah.
there.
So
I counted 3, but then I answered 4.
But so when we start at some point, perhaps seeing an increased number of sick people that have been vaccinated, that's when we probably will see the trigger pulled to really seriously consider some sort of booster, if you want to call it that.
Yeah. Although but we're not trying to boost immunity per se. We're trying to broaden it.
Yeah. So you said early in our conversation, George, that the epidemic's not over in India. That's obviously clear. And although I think even there, it looks like maybe they've passed the peak of badness. But you've done tons of work in a ton of different countries, and you look in sub-Saharan Africa, and Nigeria is a gigantic country with a gigantic population. I've heard it may surpass India within a few decades. Well, I've heard that, but of course,
I don't dispute that you've heard
that. I've heard there's a lot of election fraud too. But you had this massive outbreak in India, but another, and you could pick others, but other populated poor countries with limited healthcare capacity have not seemed to have that scale. Why is there such a difference in the way countries are being affected by this? Any guesses?
It's all guessing, right?
Yeah.
I mean, what India got was the B117 mutation, the UK mutation in northern India, and that seemed to have triggered a second wave of infection. And then they had the B351 mutation later, the so-called dual variant, which actually has 13 mutations on it. But it's they had some bad luck, some serious bad luck with variants before anybody was vaccinated. India still only has 5 or 6% of the adult population vaccinated. So, India has a sophisticated medical system. And so they're in a position to diagnose a lot of people. If you look at the 3 largest African countries, Nigeria, Ethiopia, and South Africa is really probably the only one that's in position to, do the right thing and figure this all out, to figure it out.
Yeah.
And they've had 40,000 cases. So I'm not quite sure what's happening. What you have to remember about Africa is the youth bulge in Africa. There are a lot of people who are young in Africa. And it's a big chunk of the population, to the extent that younger people don't get as symptomatic and don't present for diagnosis. Then I think you're going to see, this may be happening at an asymptomatic, mildly symptomatic level. And you're really not seeing a lot of symptomatic cases among older people. Having said that, though, the president of Nigeria died, president of Tanzania
died, yeah.
Died of COVID after, not saying there was no disease and suppressing all the data. So, I think it really remains to be seen. The next big ground the big area now where there's a lot of transmission is the southern cone of South America, where they're just going indoors through the winter. So this is every place from Brazil we've known about for a long time, but Argentina, Uruguay, and Chile all have large outbreaks. And the Chilean one is particularly interesting or distressing, depending on what side you're sitting on, because they have a largely vaccinated population, much as the other place that's experiencing the Seychelles in the Indian Ocean. But they've used a lot of the Chinese, sort of that first generation Chinese vaccine that's basically a whole killed virus product. And that might be what's going on with them.
Great. George, people don't probably know, but they should, that you've had a huge role in the response to this pandemic in San Francisco with the case contact finding, and you've thought about that and other diseases, I know, in your career as well. So did that work? Was that part of why Northern California has been relatively spared? How can you guess about the cost and cost effectiveness of case contact finding as a strategy? And what about places where they didn't ever try it? Is there any lessons that you think you learned at this point?
It's hard to say, Paul. I mean, it's first of all, trying to figure out how much it costs is anybody's guess. I mean, it's a lot of sunk salaries, but you have to realize in San Francisco, there are a lot of people whose salaries were already being paid that just got repurposed to doing this. My favorite were all the city librarians who were absolutely terrific at it. It's hardly free, and it's a lot of kind of person power to get it done. It's also very dependent on the population of being cooperative, not only with naming names, but also staying in isolation and quarantine if they've been infected or exposed. That's the part that I don't think if we were going to do this again, I think we'd want a lot closer tabs on people. Maybe not quite like the East Asian countries have done it, where it's pretty,
draconian. Yeah.
Or that's a word for it. Yeah. It's pretty serious stuff. but I don't know that we can pull that off. The other thing I think is the kind of the lost promise of all the electronic notification systems. I think those have the potential to work if you're, walking around looking down at your phone all day long. But I could tell you, the people we worry about, the older people, people who are doing day labor, who are, going to be somewhat less sophisticated with electronics, it's just not going to work, right? I mean, I think it's great for undergraduates, and I think it's great for high schools and stuff. And we may still see some really good examples from that. But I think in kind of at the beginning of this, in the larger risk pool, it just wasn't, it wasn't that far along to really be able to, kind of divide it up. If we could get 20-30% sort of scraped off the top and having it happen automatically, I think that's great. But a lot of the people we're dealing with didn't really have those kinds of resources.
So even though you're doing case contact finding, following through and making sure that the people that were at risk, who should be quarantined, actually followed through, it was hard to do that.
Well, it's not hard to quarantine them. It's not hard to tell them to be quarantined and isolated, but where are they going to put it? You have five guys sharing an apartment. It's not exactly a happening thing. And, we took over a lot of the hotel space in the city, and moved a lot of the homeless off the street to protect them and to, protect further ongoing transmission. But still, there were not a lot of deep plans about how to do this beforehand.
Sure. Well, understandable. Although I think hopefully, well, let's talk about that. So what's your thought about, so Laura Garrett says we should have been kind of better prepared. I think probably a lot of people agree with that. What do you think we should be doing for the next pandemic? What's your takeaway so far?
Well, I think first of all, we have to realize that, nature is as much of a challenge as foreign governments are, or as terrorist organizations. I mean, I think you have to put it up there on a threat list, because lots of stuff happens that, that we're just not, as we see now, that, that people aren't used to dealing with, right? They're used to dealing with foreign governments. They're used to dealing with crime. They're used to dealing with terrorism. They're not used to dealing with, the whims of Mother Nature. So I think that's one thing, is that the pandemic office needs to be reestablished in the White House. And we need to move this up to a much higher footing and get a big international treaty about this. A second thing I think that we need to do is that we need to reestablish the surveillance systems, which we're in the process of doing. I don't know if people knew this, but USAID killed our zoonotic surveillance system, including a zoonotic surveillance system for bats with beta coronaviruses in Wuhan in October of 2019, in a particularly prescient move.
Good timing. Yeah.
Good. Perfect timing, and nobody got in trouble for it, I'm sure. So I that all has to be reestablished. And I would hope that we'll be working, I hope, with Davis to do that, the University of California, Davis and School of Veterinary Medicine, which has a huge presence in this, in the field, and 1 million partners all around the world. That's the kind of stuff we need. Having said that, those are kind of two big ticket items. I think we need to have more detailed plans and about what we're going to do next time, because there will be a next time. It's just what we're going to need to do. And if we're going to need to do contact tracing, we need to figure out how to do it more efficiently, where we're going to put the people. So the Chinese, the Taiwanese erected sort of temporary hospitals to house people who are quarantined or isolated. I mean, we're hesitant to do that, but I think that's the sort of thing that we should be ready to move on. Where are the people going to come from? What kinds of electronics are we going to use? What sort of laboratory capacity do we need? I think one of the other great sort of sins of this early epidemic, which sort of falls under the overarching category of hubris, was not having enough, not using the test capacity that was available, and infighting between CDC and FDA, and not moving out to commercial manufacturers for getting the kinds of testing capacity that we needed. My daughter had what clinically was my oldest daughter had very clinically was very apparent to be COVID, complete exact course. Got at the supermarket, when she was masked having to go to the market. This is in Virginia, not a test to be had, not a
Yeah.
test to be had. And this was in like mid-April last year, right? It was pretty deep into it. And that's stuff that just shouldn't happen. The Chinese had the capacity to test for this by mid-January. And then the Europeans developed it pretty quickly. And we're sitting around with CDC that made a decision that there'd be a few hundred cases of this, and we'll do it like we did pneumocystis in 1981 for HIV,
Right.
and we'll be able to control all the drugs and the reagents, and we'll know exactly who's who. Well, they were only off by 3 orders of magnitude. So,
George, you've mentioned a couple times now China and Wuhan, and that's been hitting the news again the last few days. Thoughts on where we are with this ongoing investigation about where this virus came from, and what's your thought?
I think it's important to know. I think that a lot of this is political, obviously, but I think it's important to know what situations these kinds of outbreaks occur. There are another 4 or 5 bat beta coronaviruses in East Asia.
Yeah, I was going to ask you about that. Are they the next thing?
Yeah, probably. I mean, influenza is always the next big thing. Influenza A is the next big thing. But those are not low likelihood events. Those are, I think, we might see another one, maybe not in our lifetime, but in our kids' lifetime, and that's what we need to be kind of up and prepared to take on. But I think it's interesting to think about this as how exactly did it get from bats to people? I think the laboratory part is probably not right, but I'd still like to know the actual chain. And does it involve pangolins? Does it involve, some other intermediate species? What exactly is going on? Because that's how we're going to have to, base the surveillance.
George, there are a couple questions that people have sent in and that I've been tossing around as well about this, the whole heterologous vaccination. So if you've been vaccinated with one company's vaccine, does it make sense to, again, going back to your statement, broaden the immune response by intentionally using a different vaccine next time? I guess this is not exactly the same thing as the next round of vaccines that will be re-engineered, but what's your reaction to that discussion?
I think that it's, the recommendations is you use the same product that you were first vaccinated with. That's what we've tested. That's what we know that works. I think the chances of the 2 mRNA vaccines canceling each other out or having greater side effects are probably pretty low. And even CDC acknowledges that if you can't get Moderna, you can use a Pfizer. If you can't get the Pfizer, you can use a Moderna. I think that stuff's fine. I don't know about mixing mRNA and adenovirus vaccines. That's probably pushing it a little too much. But I would not go out of my way to try and engineer that as a vaccine strategy. I think just stick with what you have. We know that it works, and we know that it works spectacularly well. So why mess around with it?
So without getting too very political, what's your current thought on the CDC? A friend of ours, Rochelle Walensky, is now the new director. How do you think she's doing in terms of the communications and decision making that we're seeing so far from the new CDC? Are things better?
It's night and day better.
Yeah.
I think. I mean, there have been a few missteps. We were this business about outdoor transmission and summer camps. She got kind of ambushed by that, but but it's. I think it's a lot better, and you feel like somebody who actually is at the helm who's trying to do more than hold the line.
So I'm looking at some of the questions that are coming in from the group, and you can put your questions in the Q&A, and I'll try to keep track of it. But One of them is about vaccinated nursing mothers. So, should vaccinated nursing mothers prolong breastfeeding beyond the usual recommendations in order
Well,
to
I'd be interested
transfer?
if as an internist, you know what their usual recommendations are. I mean,
Well, I'm guessing for my granddaughter that switching to milk should start about a year.
yeah, that would be outstanding. That would be great. It's nutritionally, there's not enough, you can't go much more than a year, but yeah, I mean, the longer you breastfeed, the better. And the WHO, asks, really wants people to exclusively breastfeed for 6 months, which is probably, that's pushing it a little bit, I suspect. But yeah, I mean, I think that, most of the antibody transfer occurs in the colostrum in the first few days of life. So, I mean, it's all socialization and nutrition after that.
Got it. Got it. So earlier in the conversation, you mentioned that vaccines might not be as effective, and we're certainly seeing this in solid organ transplants and other people with various kinds of immunosuppression. Two
Yeah.
questions, because this is an HIV/AIDS audience to some degree. What do we know about people with HIV and their response to vaccination? And for those people that are definitely immunosuppressed, let's say solid organ recipients, should they be covered with monoclonals? Because we know that the vaccines aren't working very well on those.
Yeah, I mean, I think this is an evolving field, and we're going to have to figure it out. For right now, somebody with HIV who's virologically suppressed, I think has perfectly reasonable chances, the same chances as anybody else of having a robust vaccine response, which is exceptionally high. If you're unsuppressed and you get infected, and this is one of the scenarios in South Africa, you may have prolonged infection, and which is how we breed variants, is these multiple replication cycles in a single host. So that's a concern. I suspect what will happen going forward is that we'll need to, first of all, there'll be some really specific guidance about this that will come out. And it may come out from the rheumatology societies, it may come out from the oncology societies, it may come out from CDC. And some of the things to consider is, should you be checking people for spike antibody to the spike protein?
Right.
Should you be giving them a third vaccine? Should you be covering them with monoclonals if they get exposed, like post-exposure prophylaxis? Some of those trials are ongoing right now. I mean, for right now, I can't give you a real clear answer to the question. But what I can tell you is that the European Rheumatology Union, or whatever it's called, issued guidelines for a variety of vaccinations in the face of people on immunosuppressive therapy. And it was actually before COVID, but you can kind of translate it over to COVID. And it's, if you're on, X monthly methotrexate, for instance, or something, you'd probably want to give the vaccine like right before you give the next dose of methotrexate, to try and get a peak and a take. Or if you're, you might skip a cycle or something. But it's, I know about pediatrics. I don't know a lot about rheumatology. But there are good guidelines about it that I think you could probably generalize from. But basically, if you have patients in this kind of group, you might want to talk to a local infectious disease person to see what his or her advice might be.
So an interesting question from one of the registrants about, we don't really hear a lot about people who have had COVID-19. What should we be thinking about them? Should they be, are they protected? Should they be vaccinated? Are there any risks of vaccine in people who have had COVID-19?
Sure. So the current recommendations from CDC are that people who've had COVID-19 need to get vaccinated. Some of the European countries, France, for instance, has said they only need a single dose. That may be as much about vaccine preservation as anything else, but something like that. And I suspect we'll get some additional guidance from that coming up. People who've been naturally infected have had less robust immune reactions than people who've been vaccinated. That's how well the vaccines work. and probably have more rapidly waning immunity, and may or may not be that protected. And we've had a number of cases of people who've developed a clearly documented second infection. So it's not a get out of jail free card, having been previously vaccinated, but previously infected. But if you look around the country in places where there have been big outbreaks, you see a much more rapid fall off of incident cases, suggesting that whatever happened in the last big surge still has still is providing immune protection at the population level. We're seeing this in Los Angeles, where there were horrendous outbreaks in December and January. And they're now down to, I mean, it's going to still sound like a lot, but they're down to hundreds of cases a day, down from tens of thousands of cases a day.
So, question about kind of long-term strategies now. What's the likelihood, assuming that that the rich countries can get their act together and start really getting vaccines out to the rest of the world? Is this a pandemic that we can eliminate? Is it one that we can control? What's your best guess about where we might see this go?
My best guess is that we'll be able to control it, but not eliminate it. We really don't have that kind of vaccine coverage, even in this country, even in the state, Paul. And, think about being able to do that around the world, I think is, unlikely. So I would say that, we're going to be one of the routinely administered childhood vaccinations that may need booster doses or may need additional doses every once in a while. But that's kind of the best that's the best my crystal balls can say at this point in time. And it's just something we need to be following closely.
So another thing that we've been hearing about in the news increasingly, I think recently, is the issue of mandating vaccination for healthcare workers. I saw the thing in Houston. I think healthcare workers are suing to not be required to be vaccinated. Colleges have struggled with this, I know, in a number of states. What's your guess from what you've heard about where we might be going with mandating vaccination for different groups?
I think we'll end up I think we'll end up with some vaccine mandates. Frankly, it would help to have a formal license for these drugs first. But I think once that happens, then we can move to have mandatory vaccination. I mean, the military is not mandatorily vaccinated. So that would be like a place to start, law enforcement. I mean, I find it somewhat scandalous that that people working in nursing homes and providing elder care and stuff are not required to be vaccinated. That's another place I would start pretty early on. The University of California system is going to require vaccination next year, but it has exceptions written in, philosophical exemptions and medical contraindications. And the only medical contraindication is anaphylaxis to the first dose of the vaccine or the components of the vaccine. So that's going to be a relatively narrow series of contraindications. So I think we're going to, we'll see it, and how many people will manage to get out from it. It remains to be seen. And what do we do with them remains to be seen, as those people are going to be screening 2 or 3 times a week to make sure they're not infected. Again, there's not a lot of risk to vaccinated people, but if you get a lot of unvaccinated people together, you can have, spreading and have sustained transmission, which is something we're trying to get rid of.
So thoughts about alternative approaches, diet's effect on COVID. Any thoughts about that? I mean, I'm guessing I know the answer, but why don't you help reassure us?
You like strings of garlic around your neck? Is that what
I think so, or vitamin C. We've seen it before.
Actually, Linus Pauling taught me chemistry at Stanford. So
there you go.
See, it's a good source of renal stones if you take a lot of it. I don't think so. I don't think there's really anything there. I mean, the question is, think of a nursing home where there's all of a sudden a couple of cases. If this were influenza A, we put everybody on prophylactic antivirals. This is the antiviral society, right?
Right.
We put everybody on on prophylactic antivirals to the end of the spring. I think we might see something like that happening. Now, it's probably not remdesivir. It might be monoclonals. We'd have to see, and a lot of it would depend on what variants are circulating and things like that. Because the monoclonals can be blocked off with relatively minor changes and configurational changes. But it's, I could see scenarios like that happening. There might be post-exposure prophylaxis in households, certain situations, military barracks, college dormitories, things like that. But I think that's probably all we're really talking about besides beyond vaccines. The vaccines have been so spectacularly successful. There hasn't been tons and tons of thought given to this.
So
That's not fair. There actually has been tons of thought given to it. It's just how practical it is in the face of such successful vaccines.
George, you mentioned just a minute ago, I hadn't really thought about it, but that the military is not requiring COVID vaccination. And yet I've seen all sorts of photos of, recruits standing in line, getting about 1 million different vaccines all at the same time. Why can't they include COVID vaccination in their intake?
My understanding is it's because it's not licensed yet. Now that may be a legalistic
Got it.
Construct, but that's my understanding of it.
So one person wants to go back to your comment earlier that you think air travel is not a big risk, but that long haul air travel might be more of a risk. And he or she specifically says, okay, let's talk about flying to India, flying to Europe. What would you do practically in terms of that long travel?
I think I may have been misunderstood. I said that the airplane outbreaks were on long haul planes. They weren't on the short haul planes. So if you're vaccinated, I think you're vaccinated. Now the FAA is going to require you to wear masks right now. Okay, so let's just be clear on what the biological risks are and what the rules are. And first of all, I wouldn't be flying to India if I were you at this moment in time.
I'm not sure you're allowed to, right?
Yeah, I'm sure you're certainly not allowed to fly back. I think if you're going long haul, you just increase the chances of being exposed to somebody. If you're vaccinated, though, it doesn't really matter unless you're a solid organ transplant or something like that. And I would be, I'm pretty sanguine about it all. And, if I could get I had hoped to go to Europe a couple of times this summer, and I still hope that I'll be able to go. I'll wear a mask on the plane. I'll try and do the sorts of things that you do to minor things you do to mitigate risk. But, I'm not going to be very worried about it.
So another question is, how confident are we that what we've been seeing, the fluctuations in the cases in our country, for example, is really a result of vaccination uptake versus other things that might be happening, such as changing in the weather or following distancing and other guidelines? Are you confident that most of what we're seeing is vaccine related?
Most of what we're seeing is vaccine related. What the part that's not vaccine related is from naturally acquired immunity. You can plot vaccination levels versus incident cases, and it's a pretty straight relationship.
So another person puts in that studies in Israel, where the vaccine uptake has been very high, shows kind of more than a 1 in 10,000 breakthrough infection after vaccination. What's your thought about?
Yeah, I mean, CDC put that number out. They actually didn't put that number out per se. They put out something that, you had to do the math to get to that, but it's on the order of 1 in 10,000. In the trials, it was 1 in 1,000 and 1 in 2,000 for the two separate vaccines. And I suspect that's really what we're talking about here. The J&J, because the trials were being conducted in South Africa and Brazil with some pretty
harder variants. Yeah.
Harder variants was more like 1 in 300. But, measles is 95%, right? So it's not, that's not fair. You have to be exposed to get it. But it's, I think those are what the real numbers are. But again, what we're trying to prevent is death and severe disease, right? And I think that, using these cross matches between the immunization registries and the cases and the case registries, it's a perfectly legitimate way to do that. We may put up with more background circulation going forward now, but I think that keeping our eye on cases in hospital, on severe cases and deaths is a not unreasonable way to do it, as long as we have other kinds of systems that are looking very directly at what the failure rates are.
What we've been hearing, not in the last week, but maybe a couple of weeks ago, we were hearing a lot about side effects of vaccines, the various clotting disorders and other things. How well are we monitoring for side effects of these huge vaccine distributions?
Yeah, I think we're doing a pretty good job of it. The latest one is myocarditis in adolescent males, which is hard because we're just entering the enteroviral season, and Coxsackie is the leading cause of myocarditis, and it's always in adolescent, or not always, but it's disproportionately in adolescent males. So this is the problem with vaccination programs, universal vaccination programs. Anything that ever happens after it is the vaccine's fault.
Yeah.
Well, you have to sort of prove that it didn't happen that way. CDC has some cautious guidance around myocarditis. Basically, it's mild. It goes away with NSAIDs. Few people have been treated with IVIG. Intravenous immune globulin, but it's not. Their advice is don't slow down, just keep going. But people are on the lookout through this. If you have side effects that you'd want to report, there's a system called the Vaccine Adverse Events Reporting System, VAERS, or VAERS, V as in Victor, AERS. And that's how you can report cases to that. You can also query that. There's a database there you can query. So you can say, well, how many cases of, let's say, polymyalgia rheumatica occurred after the Moderna vaccine? You can look that up. I don't know how up to date it is, but it's within a week or so, I'm pretty sure.
So a number of questions about the chronic COVID condition. I'm not sure it's got a great name yet, but what about the effect of COVID on the CNS? And what more can we say about those people with long symptoms of this disease?
Yeah, I don't follow these patients, so I don't have kind of real, firsthand knowledge of it. What I can tell you is that it's real, that there is prolonged symptomatology, that people talk a lot about, aches and pains and sort of changes in mentation, so-called brain fog, which is not my favorite term.
Right.
Paul and I, living here in the Bay Area, we're very sensitive to the issues of fog. But I think that's it's all very real, and and we don't have a lot of therapeutics for it. One thing that people have talked about is vaccinating people with these long COVID symptoms, with the thought, probably somewhat simplistic, that there's a nest of replicating virus someplace, and if you give them vaccine, you're going to wipe out that nest and the symptoms are going to go away. It's got to be more complicated than that. But I know that that there has been discussion about putting trials together. They may have started already, for all I know. And I think the third thing to say is, this sounds an awful lot like chronic fatigue syndrome and myalgic encephalomyelitis. And maybe we'll get some insight into those sorts of longer term, post-infectious syndromes from this. I would hope that there'd be some silver lining to all of this.
Yeah, I think that's going to be a fascinating area to follow. I think the skeptics about chronic fatigue and all the rest. I think we're going to have to kind of backtrack on some of that. I think we're going to find that the overlap is really quite striking with this long COVID, and maybe it'll lead us to more ways to approach therapeutics for people with those other conditions as well.
I suspect COVID vaccines, and it won't be one of them. But
not a COVID vaccine. But so a friend of mine asks, free to comment, and I know this story. Manaus, Brazil. They had a huge outbreak. It looked like they had herd immunity, whatever we think about that. And yet there was another big outbreak. Does that make you kind of wary about being confident that we're going to control this?
Well, that's naturally acquired immunity. That's not vaccination.
Right.
I mean, the first thing about that, and I've done a lot of work in Brazil over the years, and I know a lot of these people who did this stuff, who are all very careful virologists and are really, have impeccable credentials. The estimation of what prevalence of disease was came from blood donors. And, how representative blood donors are in a state capital in the middle of the Amazon basin are of everybody living there, I think I think that's a stretch. We wouldn't base, big decisions on what the prevalence of anything was in blood donors here. So that's the first thing to say. And the second thing is there was a big variant change. And yeah, it's more complicated, more problematic. The same thing has happened in Iquitos in Peru. And so it's, we'll have to see. But again, this is not about vaccines holding the line. It's about naturally acquired immunity holding the line. And to the extent that you get really big shifts in variants, maybe it will, maybe it won't. I can tell you that right now in California, based on the surveillance systems that are currently available, about 6% of the variants, 6% of all genotype isolates are the Brazilian P1 variant. So we may be seeing it pretty soon here and finding out for ourselves.
So you said something interesting earlier, George, about places that have the vaccination has been with the early Chinese or maybe with the Russian vaccines.
That was Chinese.
Yeah, but the question here is asked specifically about Sputnik or the Sinopharm vaccines. Do you think that areas that have been vaccinated with what arguably might be a less effective vaccine will remain on travel protected lists compared to places that are more heavily vaccinated with mRNA, for example? Is that going to be a factor in decisions?
Well, there's really no place that's being vaccinated heavily with mRNA besides the United States right now. Everybody else is getting adenovirus vaccines. The Gamaleya vaccine, the Sputnik 5 Russian vaccine, that's an adenovirus vaccine that's seems to work really well in terms of published results. We don't have a good handle on his side effects and whether that's part and parcel of the same kind of heparin-induced thrombocytopenia syndrome that's been going on with AstraZeneca and now more recently with J&J. I think that, and I get that, I'm sorry, I should say that I think it's Sinovac. It's the whole killed virus vaccine.
Okay.
That was, and I could easily be wrong on the names. That's been going on in Chile. Maybe, maybe not. I think it's got 62% published efficacy, which is, like a lot of the vaccines, is a lot more than it's twice what the influenza vaccine is every year. I suspect if we can get lots and lots of people vaccinated, it'll be relatively well controlled. You have to realize that vaccine is being used extensively in Mexico right now. So it's, we may get a real up close and personal look at it too.
Yeah. So Les Squires is a great HIV doc. Hi, Les. Wonders, again, going back to HIV, is there a CD4 count that you would worry about responding? Do we know enough about that or viral load in terms of HIV in response to vaccination for COVID?
Now, we did a cross match of the COVID and HIV registries here. They're not real patterns. They didn't seem to be at any particular greater risk. If you look across the published HIV literature, yeah, there is some increased risk for more severe disease. It's not about getting it or not getting it. It's about having more severe disease versus less severe disease. And I don't know that anybody's really looked hard at what a CD4 count is or a viral load is, but I can tell you that to my mind, if you have unsuppressed viremia and T-cell lymphopenia, you're probably at greater risk of progressive disease and prolonged disease, which is what the real kind of public health concern is, because that's what breeds variants, this sort of constant replication in a single host.
So I have an interesting question. Are we concerned about possible recombination of viruses? What about this SARS-CoV-2 with MERS or other coronaviruses? Is that something people are looking for at all?
No, I don't think so. I mean, so in the land of viruses, sorry to be pedantic here,
Yeah, yeah.
you got your RNA virus, you got your DNA viruses. On the spectrum of RNA virus, this is a big RNA virus, which means that it has an enzyme, a polymerase enzyme for detecting mutations that works pretty well. This does not mutate very fast, maybe once every, somewhere 1 to 3 replication cycles. So it's not like HIV with this constant shower of mutations. It's a little bit more controlled. And for that reason, I think that Jay DeLevy is probably going to come up and call me in 2 seconds to tell me I'm all wrong about this. I think that having actual sort of wildly different variants and recombinants is unlikely.
So there's a question about oral medications close to approval for outpatient treatment. I'm right now on several data safety monitoring boards for clinical trials. I think it's safe to say, at least I'm not aware of anything that's imminent in terms of a new oral medication for outpatient treatment. Obviously, we're still repurposing a lot of meds that were here for other indications that haven't really so far been showing very much effect against this one. George, you want to comment on that?
I don't follow that. I don't follow that stuff very closely, but I know that. Well, I wouldn't be surprised.
So here's a question that I like. I'm not much of a
first time for everything, huh?
Yeah. I'm not much of a singer, but I know that there was concern in the early pandemic about transmission in choral groups, singing. Are we to the point now, if the choir has been vaccinated, that they can come back and sing loudly to each other?
Yeah, I think so. I think if they've been vaccinated, I think if they've all been vaccinated, I think that's very doable. Well, I've done actually some work with the San Francisco Opera, and if you can imagine importing somebody from Italy to come and stand on the edge of a stage and spit on 75-year-olds, I throw in with a kind of higher risk situation. But there's been a lot of work around trying to mitigate risk from singing, especially in these settings and rehearsals, and by big distancing. You have to get 12 feet in front of people who are singing, and it's the same kind of thing with wind instruments too, especially ones that are woodwinds where you're much more likely to, think of a flute where you blow across the top. So there's been quite a bit of work done with those, but I think we're really at the point now that as we get everybody vaccinated, we'll be able to kind of back down the cautions. I mean, I don't know that I'd be wanting to sit in the first pew when the choir cuts loose with Ode to Joy or something, but I think that there might be some additional mitigation that's going to need to go on for a while. But here in California, the governor said that on June 15th, everything goes unless you're in mega events with 5,000 indoors or 10,000 outdoors. So it's I think this is all probably going to fall under the allowable guidelines.
Got it. So we've been watching Canada pretty closely, our near neighbor. I think there was a bit of a slow start with vaccination, but one of the participants says that they're now predominantly using mRNA vaccines.
Oh, they are? Okay, great. I thought they were using all AstraZeneca. That's good.
And another question, I think you answered this probably, but negative consequences to receiving an mRNA vaccine after the AstraZeneca.
I don't think anybody knows,
right.
Frankly. And, I probably wouldn't mix and match.
And then here's one I have no clue about, but one registrant wants to know about, says, we know many mutations on the spike protein. How much do we know about mutations of RDRP?
RBD or
RD? I think it's another protein of the virus.
I don't know that we know much about it. If we're talking about RBD, the receptor binding domain at the tip of the spike protein. We know a lot about that,
Yeah.
but I suspect this is something else. I just don't know. I'm sorry.
And again, a fair number of questions about kids and schools. Do you want to give us a
Sure.
kind of a couple sentence summary of that again? I know you started by going through that.
So I think that, we'll be able to vaccinate. I think most high school kids will be vaccinated in the United States going into the fall. And I think most middle school children will be vaccinated going into the fall as well. It's the elementary school children from 5 to 11. The trials probably aren't going to finish until October. Hopefully we can move quickly to an emergency use or even to a full expansion of a BLA if that exists, the actual licensed thing, if that exists. But until that happens, I think elementary schools the kids are going to have to be masked and have to have some social distancing. I think if we can get I think the high schools are going to demand similar things unless they can move to make vaccines mandatory, or at least to have most people vaccinated.
And
again, these are decisions that are made district by district.
And the RDRP is RNA-dependent RNA polymerase. And I think probably George or I don't have the answer to that.
No, that one's fine.
Sorry, I'd like to believe I know everything, but I don't. So we're really right at the end of our hour. George, you've been spectacular. I think one of the questions that we've talked about in the IAS-USA is whether there's still a value in these dialogues. George is willing to keep doing them. I'm willing to keep doing them. But maybe we could have you kind of let us know by email whether there is still a value in these, and if so, kind of which areas do you want us to really try to focus on? We intentionally keep it pretty broad, but George, you've been spectacular again. And I'll thank the IAS-USA staff for really great effort in putting this together. We had over 200 people on the call today, so
Wow.
good going. And here we have some other information about other programs that you can find on our website. All right. I think that concludes the program. Thank you.
Thanks, Paul.
Yep.